Primarily what we were talking about is looking at identifying the walls that we talked about. The anterior, the lateral, the septal, the inferior. Posterior is one that's there also, but we don't normally look at it. But the other way that we can attach leads to the back of the patient. In this case, 7, 8, 9 are roughly the same as V1, V2, I'm sorry, V2, 3, and V4, to give us a view of what that posterior portion of the heart looks like. In fact, we can even do it on the right side. Now remember, we're assuming that every patient that we're doing an EKG on has a heart that is on the left side of their chest. There are, however, certain conditions, situs inversus or dextrocardia. Dextrocardia means the heart itself is on the opposite side, so it's on the right side. Situs inversus is where everything is switched. Your liver is on the left. Your stomach is on the right. Why? Because that's the way the good Lord made us. It's kind of one of those things. In those patients, once we've identified that, they usually get a wristband that says that they have that condition. So when we do the EKG, we know that we have to place the leads in the opposite position. And this is what we're talking about, doing a right-sided ECG. One of the reasons we'll do V1R, V2R, 3R, 4R, 5R, 6R, is if we have a inferior wall MI, inferior wall, bottom of the heart. The inferior wall is typically fed by the right coronary artery. Okay? The coronary artery also feeds two structures, the right ventricle and the conduction system, the SA node, the AV node. So inferior wall MI, when we see those, we think, well, could it possibly be that there's a right ventricular infarction also there? Not just the left inferior wall, but also the right side. And we would verify that by hooking them up and doing an EKG where the chest leads are on the right side as opposed to on the left side. And the cardiologist from that can interpret it as such. A little bit different. Again, we talked about it, secondary to an inferior wall of the left ventricle. Usually when they're hypotensive, and again, we confirm it with a right-sided ECG. And again, this is kind of what they look like. If you notice, we're looking at some right-sided problems where the right side of the right heart is not functioning, so it's backing up, creating jugular venous distension, creating dyspnea, even though there's no crackles that we would end up seeing. And the treatment is totally different than what we would do for a left-sided infarction. So it really does make a difference. Not common, but can occur. The posterior, we can actually have a 15-lead EKG, which is more sensitive. Every time you add another view, you get some more information. And we do this a little bit with pediatric patients also. So we're doing all these additional leads that are placed onto the patient. And kind of give an idea, though. Don't expect you to memorize these, please. Let's just stick with the standard 12. I'm just bringing it out that this could be something that would be requested of you. All right. Another, yeah.
So you're saying for right ventricular infarction, isn't an infarction, does that mean that it's dead and you can't do anything about it?
Well, or we're in that process, that evolving process of ischemia, injury, and infarction. When I say myocardial infarction, recognize that we're trying everything we can do to prevent that actual from happening.
Okay.
But we're seeing the ischemic changes, we're seeing the injurious changes, so on and so forth. Axis evaluation. Axis evaluation is giving us an idea what direction the flow of electricity through the heart is going. Normally it goes from right to left and top to bottom. Goes from basically the right shoulder to the left leg, lead 2. right? That's why we use that as the idiot's lead. Some conditions, though, change that. And we can use that as a diagnostic tool to see if that disease is present or not. So normal axis deviation, remember we talked about this pi. We're going to divide that pi into fourths. Okay? So we're going to have a quarter that is in the upper right, a quarter in the lower right, a quarter in the lower left, and a quarter in the upper left. And yeah, you can break that down even further into thirds within that quarter. Okay, we're not going to be that geeky. Okay. Under normal axis deviation, the current goes from the upper right to the lower left. So it goes right to left and it goes up and down. Fair? If that's the case, they would always have a positive deflection in leads looking in that direction, like lead 2. Two things that you want to know, and two things that I would ask you on an exam, just saying, are the presence of hypertrophy and the presence of infarction. It moves toward hypertrophy. So as the size of that muscle mass becomes larger, it's going to cause the current to go in that direction. Well, that makes sense. So if I have right ventricular hypertrophy, it's not going to be from upper right to lower left. It's actually going to be from upper right to lower right, because the current's following that right ventricle being larger. We'll come back and I'll go through that again in a little bit. So hypertrophy draws the axis towards that hypertrophied vessel. Infarction pushes it away. Because it's dead tissue, current can't go through there. Once I lose that muscle mass, electrical current no longer goes through. So that propagation of that depolarization wave stops and turns around toward hypertrophy, away from infarction. So in the case of right ventricular hypertrophy, what we call cor pulmonale, I'm going to see an axis deviation that's pushing towards that. Same would be true with left heart failure, CHF, where the left ventricle becomes large. That enlarged muscle mass changes the direction because there's more muscle to go through.
But if it's going to the left, isn't that how it normally?
No, it goes even further to the left.
Okay.
Hold that thought. And away from an infarction, as we said. Dead tissue can't go towards it. It actually goes away from it. So we're going to divide that pie into 4 portions. The first one we talked about, normal axis deviation, goes from 0 to a plus 90. So it goes from 0 to a plus 90. So that bottom right wedge is considered normal axis deviation. Right axis deviation, where we see it again with cor pulmonale, right-sided failure, or with acute left ventricular infarction, away from the infarction towards the hypertrophy. Both of them will yield a right axis deviation. That's the piece of pie that's in the lower left, from here to there, in this portion. If our axis deviation points towards a right axis deviation, it's either a left-sided infarct or a right-sided hypertrophy. So far, so good? Sure, Rick, whatever the hell you say. Are you taping this? Oh, yeah. Okay, good. Left axis deviation means that we're in the upper right corner, or upper right quadrant, and that would be caused by either left heart failure, where I have left hypertrophy, left ventricular hypertrophy, or a right ventricular infarction. The opposite. So normal axis deviation, right axis deviation, left axis deviation. Fourth quadrant, upper left. We call indeterminate. It's also known as no man's land. Why is the current predominantly going left to right and bottom to top? What? It's going this way instead of that way. And there's a couple of bizarre reasons, but that's extremely rare to end up seeing. One example is a pacemaker, because a pacemaker starts on the bottom and goes up and goes in the opposite direction. Right axis, left axis, normal, and no man's land. So how the hell do we determine the axis deviation? I'm going to give you the simple method. There's tons of stuff out there. I'm glossing over this. I'm making it easy. We look at two leads, and we ask ourselves, is that QRS complex predominantly positive or predominantly negative? I look at lead 1 and I look at lead AVF. Where does lead 1, what's the positive and what's the negative electrode? With lead 1.
Negative to positive.
Other way.
On their
Negative on their right shoulder, positive on their left shoulder. So it's looking in a horizontal fashion across the chest. Right shoulder to left shoulder. Where's AVF? Center to the foot. It's directly perpendicular to lead 1. Does that make sense? That's why we're using 1 and F, because they're perpendicular. One is looking right to left, the other one is looking top to bottom. Under normal conditions, both lead 1 and lead AVF would be positive QRS complex. When I say positive, I mean that this is more bigger in size than this. So there's more positivity than there is negativity as far as that isoelectric line. Am I okay there? Lie to me. Come on, Misa, lie to me.
Okay, we're good.
And we'll give you some examples, so it'll make it more clear. Okay. So under normal conditions, the current primarily runs from right to left and top to bottom. Right to left would mean that it'd be a positive in lead 1. Top to bottom meaning it's positive in AVF. In right axis deviation, it's actually going more towards the right side. So instead of being that I got my piece of pie. This is normal. This is right. It's going left to right instead of right to left. It's going towards the right side. But it's still going top to bottom. So lead 1 will be deflection downward. It's predominantly a negative QRS complex in lead 1, where it's predominantly positive in lead AVF.
That line we're talking about, the way this it dips down, it's supposed to go from negative to positive, goes backwards.
Right.
It dips down.
Right.
Okay.
Because it's seeing more pull on the right side of the heart,
Okay.
left-sided infarction, right-sided hypertrophy. It's going to move the current in that direction. So therefore, instead of being right to left, it's left to right, giving us a negative deflection. Left axis deviation caused by right ventricular infarction, left ventricular hypertrophy is going to be this portion here. Right to left is still true, but top to bottom is not. Top to bottom, it's bottom to top. So what we'll see is lead 1 being a positive QRS complex, but not lead AVF. It's up and towards the left. Left to right, bottom to top. No man's land. It's got nothing. It's negative all the time, no matter which lead you look in. So lead 1's downward deflection, lead AVF is a downward deflection. We talked about this, just looking at different points along the line. So we can do different lead systems to get different pictures, as we talked about. Don't memorize, please. And the same thing is true with those modified chest leads. Okay. Just some information, just so you know, the speed of the paper is 25 millimeters per second. We're going to use that because we need to find out the duration of each of the little things like P wave, PR interval, QRS complex, etc. What you really need to know, though, is that the small, remember this is a series of boxes, right? The small boxes are 0.04 seconds. The large box are 0.2 seconds. Obviously, there's 5 small boxes for every one large box. Look at the paper. The height we don't pay as much attention to. That just has to do with what the voltage is. And for our purposes, we're not really getting that much into it.
So what we do need to know is what we're talking about.
Correct. 0.04 seconds for each small box. There's 5 of them, so a big box is going to be 0.2 seconds. And that's kind of what the ECG paper looks like. One of the things that you'll need to know how to do, and it'll be a test question, I'll guarantee you, is determine the rate. By looking at an ECG strip, how fast is the heart rate going? Yes, I know, it'll tell you. That's not what I want. I want you to be able to determine even if you don't have it. The easiest way or simplest way, but also the least specific way, is to just look at 10 seconds, look at a 6-second strip and multiply that number of beats that are in those 6 seconds by 10. That'll give you the rate. It's what we always use when we have an irregular pattern, but it's an easy strip, and I'll show you in a second how that process works. There's also using the R to R method. This is my least favorite, but it's some people use because I can never remember and memorize this group of numbers. So if the distance between one R wave and the next R wave, we can predict what the heart rate will end up being. The 2 other ways that are there, becoming more and more specific. First, these should be inverted, actually. Count the number of large boxes that are between 2 R waves. divide that number into 300, or count the number of small boxes and divide that into 1,500. So let's go. Any of them you want. What it'll be on the test is I have a an exam. I have a strip. What's the heart rate? Now, you can see this little vertical line here. If you have one of them and you have another of them which is off the page, that is 6 seconds. Each one of the distance between those little vertical lines is 3 seconds. Find two of them, count the number of beats between, and I have 10 seconds. What I've done is I've drawn with the blue arrows, in essence, what that was. So this is one, from that blue arrow to that blue arrow is 10 seconds. Sorry, 6 seconds. So count the number of beats in that 6 seconds and multiply by 10, and I have my heart rate. 1, 2, 3, 4, 5, 6, 7, 8. No, it's 8. There's 8 in there, so it's 8 times 10, 80. And if you look really closely, it says 81, but we won't go there. Your test question won't have that. Let me show you. So our heart rate is 80 beats per minute.
Can you do that one more time? Yeah.
Sure. From that blue line to that blue line, how many QRS complexes are there? 1, 2, 3, 4, 5, 6, 7, 8. Can't count that one because it's outside of it.
You're just counting the QRS.
Yeah.
From the arrows.
Between the arrows.
And we'll have the arrows on the test.
Or you'll have the 6-second strips. See, that line there, that's 3 seconds. It should be another one there, but it's off the page.
Okay.
Count the number of beats in 6 seconds and multiply it times 10. Option 1. And there we have the number of values that are there. So 8 complexes, multiply times 10, 80 beats per minute. It's an estimate of what the heart rate is. Next one is to use the R to R method. And what this says is that for every big box, I drop down by one of those numbers. So this is 300, 150, 100. This would be 75, but it's a little bit above that. So we would estimate it somewhere between 75 and 100. Let's call it 80. You can see it's not really precise. Plus, I got to memorize those stupid numbers. Nah, that's too much work. I'm lazy.
So we're basically going to be doing it the first way.
Not necessarily.
It's the easiest way.
It's the easiest, but it's also not as precise. It's the one we use when we have an irregular rhythm. That's regular. That's every R to R is even. That distance is that distance is that. You get somebody who's in atrial fibrillation, that's never the case. And you have to use that method. Okay? The first one. The next two are more precise because I'm using a much more precise measurement. Counting method number 1, how many large boxes are there between any two R to Rs? Find an R complex that starts on a line. Don't pick this one. Pick this one. How many large boxes are between that and a subsequent QRS complex? 1, 2, 3, not quite 4. Divide that into 300. Well, it's about 3, 1, 2, 3, and maybe almost another 3/4 of a large box going across. So I estimated it 3.75. 300 divided by 3.75 is about 80.
Are these all just estimates then?
More or less.
Okay.
But now I'm getting more precise with my fourth method. Okay? Because the fourth method says count the number of small boxes. I'm getting more fine-tuned. Holy shit, I got to count all those boxes? No. How many small boxes are in one big box? 5. So here's my point. 5, 10, 15, 16, 17, 18, 19. Divide 1,500 by 19, and my heart rate is 78.9. 79. Did they all kind of give me the same answer? Yeah. The last one is the most precise. But it's also, I got to divide. What? The first, yeah, exactly. The first one, I just got to add a 0 on the end. It's easy. Multiply by 10.
Can you say that again?
Showa.
5 boxes?
There's 5 small boxes in every big box.
Oh.
Okay? So start at my point. 5, 10, 15, 16, 17, 18, 19. And then divide 1,500 by 19. Voila.
Like too tiny on our
Those tiny boxes, right?
I'm sorry?
Those tiny boxes.
Count the number of small boxes between 2 QRS complexes.
On the example, like, it should have blown up the lens instead of it being this tiny.
Oh yeah. Okay.
So you'll be
It'll be the width of the paper.
Okay.
Yeah.
I can't count the tiny boxes.
Oh, wine. Make sense? Any of the 4 methods you can use, to me, the first one is usually easy and usually gets you pretty much in the ballpark. The 4th one is the one that's the most precise.
So basically the first and the 4th is the one we're going to use the most?
Probably. I like the 4th one because I like math. But I am the anomaly in this room. I understand that. All right. So what are we going? What are we talking about when we're talking about that PQRST situation? P wave. What does it represent? Atrial depolarization. There's a small pause then while the blood goes from the atrium to the ventricle. It's delayed by the AV node so that we get all that blood pumped out of the atria into the ventricle. Then the QRS complex is indicative of ventricular depolarization. Then the ST segment and the T wave, which allows us to go ahead and evaluate ventricular repolarization. And the important component there's 2 of them there. The PR interval, beginning of the P wave, beginning of the QRS complex, and the ST segment, beginning of the from the end of the QRS complex to the beginning of the T wave. It's just kind of a diagram that shows how it relates to where it's going through the heart, as we mentioned. Okay. So you should be able to identify the P, the QRS comp, and the T wave. Pardon me? Who's a U wave? Ignore it. Ignore it. Now notice what's happening here. Take a look at the picture and take a look at the tracing as we go through the heart. So here we're just waiting for the next beat to start. The impulse now emits from the SA node, goes through the 2 atria, and we see a rise in the P wave. Keeps on going, keeps on going, keeps on going. We can look at the P and say, is there something we can tell from it? First of all, we want to look to make sure that they're all looking the same. All P waves look the same. Do they? Not always. Sometimes they look funky. Here's an example where one is notched. It's got a little skip in it. See how it's not a normal round? It's got a little bit of a blue in there. That means something. Not the blue part, but perhaps it's very tall. That's going to tell us something also. So normally it's about 3 small boxes and normally about 0.06 to 0.12 durations. That's what that means. So we have a normal atrial depolarization. Do I want you to know the time for the P wave? No. I'll let you know what I want you to know times, because there are a few of them that are important. Sometimes they're inverted. What? They're upside down. In lead 2, there's an upside down P wave. What does upside down mean? What do we say when you have a negative deflection when it should be positive? It means the impulse is going in the opposite direction that we're looking at. So what happens if the impulse starts, instead of starting in the SA node, it starts in the AV node? What's going to happen to atrial depolarization? It's going backwards. What is backwards going to appear as? An upside down wave.
Wait, so you said a negative reflection?
A negative deflection means it's moving in the opposite direction we expect it to be. In lead 2, I expect the P wave to move from the upper right through the atria to the AV node. So it should be an upward deflection. If I'm seeing an inverted P wave backwards, that means it's starting actually in the AV node and moving up.
Can you say that again, negative deflection?
Negative deflection means it's moving in the opposite direction that we would anticipate it to, based upon that lead. Lead 2 says I should be moving from upper right down to the AV node. If I'm seeing an inverted wave, it means it's moving in the opposite direction. It's starting in the AV node and moving back towards the SA node. Now, I know what you're saying to yourself. What? Why would that happen? My SA node's now not working. And eventually we'll get to talking about these. It's called a heart block. But we're not there yet. Okay. Sometimes they're just buried. Sometimes you can't see them. Leave it at that. So I'm continuing on. Now we go through the PR interval. This is one that you should know, the duration of the PR interval. The duration from the time of the start of the P wave to the start of the QRS complex should be between 0.12 and 0.2 seconds. Why 0.1? From 3 small boxes to 5 small boxes. Bless you.
Thank you.
I think you're allergic to EKGs. Okay? 0.12 to 0.2. That's going to be important when we start evaluating the PR interval. It then continues on to the QRS complex. And the duration of the QRS complex should be less than 0.12, less than 3 small boxes. If it's bigger than 0.12 seconds, means that it's a widened QRS complex. And then the ST segment shouldn't be much variation from baseline. It should be that isoelectric flat line that's occurring after the QRS complex at the beginning of the T wave. If we're seeing it up here, we're going to call that an elevated ST. We see it down there, I'm going to call it a depressed ST. It needs some Ativan or something. It's depressed. So what we look at when we're looking at the position of the ST is we go to just after the end of the QRS complex. It's called the J point. And where is it compared to the baseline? That's what we're looking at to see that this is elevated.
Are we going to have to label one of these?
No, but you need to understand what they end up meaning. Okay. So ST segment, when we have injury, it actually elevates. When we have ischemia, it actually becomes depressed. Changes in the ST segment are indicative of either ischemia, injury, either ischemia or injury. Let's leave it there. And for infarction, it's totally something else. ST segment are indicative of injury or ischemia. Ischemia is depressed, injury is elevated. It's telling me something's going on with the heart, where the heart's not getting enough oxygen. And
Like the heart dying at that point?
if we don't do something about it, yeah. It's kind of giving us a warning that, hey, hello,
Right.
Something's wrong here.
Would this be like heart attack?
It's basically a heart attack means we've waited too long.
Okay.
But this is that evolution process. Ischemia is first, then injury, then infarction. So there is some clear ST elevation. Here's my baseline. There's my ST segment. What the hell are you doing up there? Get down from there. Right? Signs of injury going on. ST depression. Here's my baseline. There's my ST segment. Okay? Signs of ischemia. That EKG we looked earlier, where we ended up seeing some injury. 2, 3, and AVF. Okay. Those are primary signs of some myocardial injury in the inferior lead. The ST depression that we see there are what we call reciprocal changes in leads opposite of those. Don't need to worry about those yet. So then I got my T wave. T wave normally is positive. It's not tall. And there are my various intervals. Again, what I want you to know is the QRS interval, the PR interval, both of those as far as the times. 0.12 to 0.2 and no more than 0.12 for the QRS. Now, we've been using this term QRS complex, haven't we? It's actually a bunch of different waves together. Damn it. Let me define specifically what each of these are. The first negative deflection that you see is the Q wave. The first negative deflection on an ECG tracing is the Q wave. Q wave. That's my Q. In many cases, you won't even see one. If it's there, it's very, very small under normal conditions. The first negative deflection after the PR interval. The first positive deflection after the PR interval is called the R wave. And we're talking about going from baseline, up or down, back to baseline. So that little bit is Q, that little bit is R. The S wave is the first negative deflection after the R.
Q and S are both negative.
Both negative deflections. If present, after the PR interval, if there's a negative deflection, that's a Q.
S wave is first negative deflection
After the R. Now, they're not always all there. We don't necessarily have to have a QRS complex. We don't necessarily have to have a Q as a part of the QRS complex. It can be missing. So under ordinary conditions, this is what we see. Q wave, R wave, S wave. But I can just have an RS. RS. QR. Now notice what they did. This is an RS and this is an RS. What's the difference between them? Small r versus a capital R. Why? Because in comparing the Q, comparing the size of the R to the size of the S is much bigger. It's capital. The R is much bigger. It's capital. The other one is smaller. Where it really gets funky is where we have these other, we have double dipping. And we call that a bundle branch block. Remember when the heart goes down the right and left bundle branches? Well, sometimes it has to turn around and come back in the opposite direction. That's going to change the shape of the wave. So it's coming down the left bundle branch, and it runs into something where it's a dead tissue. What does it do? Turns around and goes the other direction, now tries it again. As that turning around happens, that's what causes that to happen. We call these rabbit ears. Not kidding. Okay? They look like bunny ears. Okay? And it's indicative of a bundle branch block. Okay? I thought it was just called a QRS and I was done with it. For God's sakes, Rick. Okay. So again, our major reason for looking at a 12-lead EKG is to identify the site of the injury, ischemia, or eventually an infarction. And it has to do with an inability to supply the amount of oxygen that the heart muscle needs. If I don't give a muscle enough oxygen, enough blood flow of well-oxygenated blood, it's going to complain. And that complaint is called ischemia. For those foolish people who run, you know what happens when your legs start getting crampy. It's because I'm not got enough oxygen there. If left unchecked, that ischemia can lead on to injury. And if injury is not fixed, we'll end up having infarction, which we never want to have because that's dead tissue. I'm not going to go through the slides. It's for time's sake. We call these processes acute coronary syndromes, meaning there's something going on with the heart. Under normal conditions, most often we see what are called STEMIs, ST elevation myocardial infarction, where we see those ST segments changing and elevating. However, think about it, the blood flow to the heart, the endocardium is directly in contact with the blood, so it can extract oxygen easily. It's the myocardium that we're really concerned ourselves with. So there could be a situation where we don't have an ST elevation, but we still have an infarction going on. It's just not all the way through all the layers. That's called a non-ST elevation MI, or a non-STEMI. And the last one in this stretch is what we're going to call unstable angina. And that's basically where there's periods of time where the heart becomes irritable. Patient gets chest pain, they take their nitroglycerin tablet, the blood flow is restored, and they're fine. Okay? If that happens often enough, that's unstable, that's something that we need to address also. So this is kind of an idea as far as how much we're decreasing in oxygen level as we go from a normal state through ischemia, through injury, and through to infarction. Always looking to the ST segment. Normally it's flat. We talked about the changes that would happen where it's elevated or depressed. Depressed again is associated with ischemia. Injury is associated with an elevation. And I haven't talked about infarction yet because I want to get, for God's sake, stay away from it. But what happens if the heart muscle does die? The area of the heart where the damage occurs is permanently lost. So let's take my inferior wall. My inferior wall, lead 2, lead 3, lead AVF, all looking down to the bottom of the heart. If that tissue becomes damaged, what's going to happen when the current approaches it? It can't go, so what does it do? It turns around. When it turns around, what's it going to do? It's going to be a negative deflection, specifically a prominent Q wave. We said under normal conditions that Q is really small or absent entirely. Not with an infarction. It's going to stay there forever. This is why we can do an EKG on somebody and say that they have an old inferior MI. When did it happen? I don't know. But it happened at some point because I got a Q wave there. And it stays forever. It's a marker that's always there.
Can you repeat that one more time?
Sure. Which part?
How it stays there?
The Q wave never changes. It's dead tissue. So every time that impulse comes toward it, it's got to turn around. So that Q wave will always, always be there.
So it's just going to be a Q wave.
There's going to be a prominent Q in those leads where that wall is damaged. My mother had 2 silent MIs. They discovered on an EKG that there was presence of a Q wave. And then the next time the Q wave got bigger.
Like, how do you know if it's not happening? Like, what if, could it happen right then and there? Like,
No.
no.
Because remember that arrow? It's got to go through the ischemia, the injury, and then the infarction.
Oh, okay.
Now, if we don't catch them, if we don't catch them until the heart's already gone, then that's a different story.
That makes sense.
But that Q wave develops usually within a few days and stays there forever. Unlucky. So just kind of as another view of this, what we end up seeing, first few minutes the T wave becomes tall, then the T wave inverts with the ST elevation, and then finally the ST flips itself back over with my prominent Q wave. Okay? Don't need to worry about that one just yet. Because that first one, you probably never see. Because they're at home. The peaking of the T wave.
Why does it peak?
It peaks because there's a change in the repolarization process. And it's taking more energy to repolarize.
Oh, okay.
And that's basically what it's saying here. Ischemia, the T wave inverts because the repolarization is along an abnormal pathway. ST elevation does not repolarize completely, therefore there's some positive that is there. And then the Q wave, again, is that dead tissue. What do I want you to know? I want you to know how to identify ischemia, and injury, and infarction. Ischemia, ST depression. Injury, ST elevation. No! Ischemia, ST depression. Injury, ST elevation. Infarction, prominent Q. Again, these are all in the leads that look at that part of the heart.
What was the last one? Sorry.
Prominent Q. Infarction. Dead. Dead on arrival. We tried to save him, but it didn't make it.
And now, depending on which lead you're looking at,
Which combination of leads will tell you what part of the heart.
What part of the heart? Yeah.
And then we can go even further, well, we won't, which coronary artery is involved. That's what Lori will teach you next year. Because we got to know where to put the cath. Where's the stent going to end up? Or if we're going to do surgery, which vessel are they going to do surgery on? And how many of them? The worst of them all, if you remember, let me go back a second. Oh, I think I got a slide on it. Hold on. I guess this is talking about Q wave. You can see the significance. It's not only, again, the size of the, when I say prominent, it's not only the size, it's the width. Can you see my big Q wave? First downward deflection after the ST segment. There's my ST segment. I'm sorry, PR interval. Here's my PR segment. Big Q wave. That's showing me I got an old inferior wall MI.
And that's the third one you're looking now.
That's the present of a Q wave, right?
Yep.
First downward deflection after the...
Oh, I meant like if it's on the third lead, so that means it's inferior.
2, 3, AVF all have prominent Q waves. Not as noticeably here. Definitely noticed there. Most definitely noticed there.
So you know which coronary artery just because it's...
Which one is it? What feeds the inferior wall? Partially the circumflex, mainly the right coronary artery. Okay, just want to use this for another reason. Here's my right coronary artery, here's my left coronary artery, right? They originate immediately off of the aorta after the aortic valve. So as soon as the aortic valve closes, those vessels then are there. The right coronary artery continues on down to feed the right ventricle, also feeding the conduction system. The left coronary artery almost immediately splits into two. The left anterior descending, the left circumflex. Vaguely remember this? Kind of, sort of. Okay. You want to go back to 1050 and review it, just saying. If the occlusion is here, everything distal to it won't be fed with blood. In this case, that's the anterior wall. V3, V4 will show signs of ischemia, infarction, or ischemia injury and eventually infarction. If it's here, that's the lateral wall, and maybe to some extent the posterior. Here's the worst spot. That's what we call the widowmaker, because it knocks off your anterior wall, your lateral wall, and probably your posterior wall. Oh, shit, well, what you got left? The septum. Well, that's going to do a whole lot of job pumping, right? Each of them means something different. Each of them manifest clinical signs and symptoms differently. An inferior wall MI, person's going to be nauseous and throwing up. Why? Because the heart that's being irritated is sitting on that diaphragm. What's on the other side of the diaphragm? The stomach. Nausea and vomiting is very common in inferior. Not so much in anterior. Anterior, you lost the pumping and you just have massive hypotension. Massive fall in cardiac output. So it does make a difference in the big picture of things.
You technically could have all three.
Oh, you technically could be dead.
No, I mean
we
like
call that in around the world.
In that
Yeah,
picture.
yeah. And you can have an anterolateral inferior MI, which basically that's your heart, and those normally do not make it out of the ER. So again, there's just another view of the right coronary artery and the left anterior descending and the left circumflex, which wraps around the back. And this is just kind of going through, we talked about this, anterior, lateral, and to some extent the interoceptal. Just another picture talking about the different changes that occur. I won't spend time. Troponin, I think we talked about last fall, and that's one of the chemical markers that is released when their injury happens. So as the heart starts having damage to it, it starts releasing this enzyme troponin into the bloodstream. We can measure it, and we can evaluate the severity and the degree to which the MI is present. Troponin, that's all I want you to know. And we should be able to identify elevation and depression, ST depression, ST elevation. Ischemia, injury. Don't worry too much about the QT interval for now. We'll go back and talk about that another day. We did talk about inferior being 2, 3 in AVF. The coronary artery, again, we said it was the right to some extent, the left circumflex. And I'm skipping through these because I want to get into some of the abnormal rhythms. And there's going to be about 8 or 10 of them that I want you to memorize and be able to identify. And that might make a good, not so much maybe a multiple choice, but a fill in the blank kind of a thing. First one, normal sinus rhythm. As the name implies, it's normal. What's our treatment? Nothing. Leave them alone. Normal looking P. P's all look the same. 1 P for every QRS complex. QRS complex is not wide. There's no changes in the ST segment. Normal sinus rhythm. Sinus bradycardia. Slow. P wave looks normal. QRS complex looks normal. There's 1 P for every QRS. Just the rate is really slow. Do we want to know what the rate is? How do I figure out that? 5, 10, 15, 20, 25, 30, 35, 40, 43. Divide 1,500 by 43, and there's my heart rate. I'm going to guess it's probably somewhere. This is a 6-second strip. Heart rate of 20. How many beats between 2 slashes? 1, 2. That's not good. Now, if you're a runner, maybe you'll have a heart rate of 40 if you're a conditioned athlete. Heart rate of 20? No. That's not very good. How do we treat it? All treatment begins with 3 things. Oxygen, IV, fluid, monitor. And we're going to put them on fluids. There's other things we can do for right now. I'm not worried about it. Eventually you will. By the time you graduate this program, you will be able to take an advanced cardiac life support course and pass it with flying colors.
You said all treatment starts with oxygen.
Oxygen, IV, fluids.
Every single treatment.
Yeah, I don't care who would it. Yeah. And I'll throw in there, although I had it implicitly, put them on a monitor. How about if I give you a little mnemonic to remember it by? Vomit. Vital signs, oxygen, monitor, IV, 12 lead. First thing to do when you come across a patient who you suspect is having a cardiac problem is you vomit. It's true, right? We take vitals, we give them oxygen, put them on a monitor to see what the underlying rhythm is, and we give them an IV. Vital signs, oxygen, monitor, IV, 12 lead.
What's the last one?
12 lead EKG, which is what the whole purpose is for, right? What about if the rate's too fast? If the rate is below 60, we're going to call it a bradycardia. If the rate's above 100, we're going to call it a tachycardia. P waves look normal, 1 for every QRS complex. Normal PR interval, normal QRS complex. Really, the problem here is to figure out what the problem is. What's the cause? Could be pain. Could be, yeah, somebody who's just anxious. Okay. Could be hypoxemia, though. It's one of the more common causes of sinus tachycardia, is their oxygen level is low. The body's response to hypoxemia is to speed the heart rate up. But we need to treat the underlying cause. Again, should be able to determine the heart rate by using any of the four methods. I don't have my 6-second strip. Oh, I do have them. Bum, bum. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 120. Okay? Sinus tach. Some other sinus dysrhythmias that are there. I'm not focused that much for you on them. Sinus arrhythmia is this where the sinus node decides to fire irregularly. What? Often it's associated with ventilation. Don't worry about it. I'm just putting it there for explanation. It's not one of the ones that I want you to know. Can we all agree, though, the R to R is irregular? This R to R is different than that R to R, which is different than that R to R. That shouldn't be. The sinus node is firing at an irregular rate. In most cases, it's benign. 2 of them that you do need to know. First of all, atrial flutter. Flutter, flutter. The P wave is not really a P wave. It looks like a sawtooth. Nan, 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 nan. Nan, 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 nan. And when you see that sawtoothed P wave or sawtooth pattern, that's atrial flutter. That's the characteristic finding in atrial flutter. The bottom one is atrial fib. I can't find a P wave. All I see is garbage. The atria are fibrillating. They're not conducting in a sequential fashion. There's blah, 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 like shaking a bowl of Jell-O. Atrial flutter, atrial fib. Both of them are atrial dysrhythmias that can cause problems, especially atrial fib. So flutter, again, what I want you to know about it is those sawtooth P waves. When you see that, that's atrial flutter. What we're going to do about it, it usually can lead to some problems, and we need to treat them either with some medication or even cardioversion. Atrial fib is a bigger problem. The reason being is as that heart or as that atria are just fibrillating, just sitting there, the blood flow, the blood that is in there is not being moved, so the potential for clots to develop. Those clots, when they get pumped out eventually, either go to the lungs or go to the brain. So either there are higher risks for pulmonary embolism or for strokes. What?
What's multiple ectopic foci?
Instead of one spot in the atria generating the beat, there's multiple ones. And they're not coming from the SA node. They're ectopic, meaning they're coming from someplace other than where they should. Kind of like an ectopic pregnancy. Okay?
So it's multiple spots creating a beat?
Yeah. You would have to ask me that, wouldn't you? Another example of atrial fib. Can't make out a nice clear baseline. Okay? And it's not sawtoothed. So I know it's not atrial flutter. This happens to be a very well-controlled atrial. Usually the rate is not that, the R to R is not that nice.
Why is the QRS wave like really high? Like the peak, like peaking up
The
really
tall,
Yeah.
it's very narrow,
Yeah.
meaning that it's within the range as far as what we would normally expect it to be. It just looks bigger because the P wave isn't there.
Would you say they're like tachycardic too?
Oh yeah, absolutely they are. And atrial fib often is. And here we have an irregularity. R to R is varying throughout, less controlled. One of the ways we treat this is something called cardioversion, and I'll just make mention of this, that we apply some electrical energy to the heart. It's different than defibrillation. Cardioversion and defibrillation both are electrical energy applied to the heart. The difference is when it's applied, as far as when in the ECG cycle. Defib, we don't care. Cardioversion, we care. PVCs are basically irregular beats. How do I know that this is a PVC? It's wide, bizarre, ugly, and doesn't work. Okay. Is the QRS complex wide? Holy momoly. 1, 2, 3, 4. Yeah, that's about 0.16 seconds. We said up to 0.12 is okay. The wide QRS complex. That's telling me it's ventricular in origin. It's a PVC. Reminds me of my first girlfriend. Okay. Normal QRS. Couple of reasons why PVCs are problematic when they're coupled together. They're walking hand in hand down the street. Oh, they're a nice couple. Nah, but PVCs. They're never good together. Think about it. It's an area of the heart that's firing from the ventricle on its own. Not tied to any other kind of impulse. Never a good thing. 3 in a row, we actually call ventricular tachycardia. Every other, we call bigeminy. Every third, every fourth, trigeminy, quadrigeminy. Now notice it doesn't say 3 PVCs. It's every third QRS complex is a PVC. When they all look the same, we call it unifocal. But what if there's 2 areas of the heart that are both irritable and are both starting prematurely? We call that multifocal, coming from 2 different spots. So here's some unifocal PVCs. Big uglies. The rest of it is normal sinus rhythm. So normal sinus rhythm with frequent PVCs. Here's a PVC. Here's a PVC. They don't look the same. Multifocal PVCs. Normal sinus rhythm with multifocal PVCs. Right? Little run of VTAC there. Just to get your, your underwear soiled. Because you look at that and you go, treatment, I won't worry about right now, but recognize that this could be life-threatening. So they're dangerous when they come often, when they come with friends, paired, when they come with friends from different neighborhoods, multifocal, I like the way it thing, or when they come at a bad time. The worst time they have a PVC is when the heart is in a repolarization state, T wave. You have a PVC that jumps onto the T wave, it puts you into VFib. Your heart it doesn't know what to do. I'm repolarizing, and now you're asking me to depolarize? Screw it. And it just stops. Not good. So VTAC. All ventricle beats, all wide uglies, and it's over 100 beats per minute. Ventricular tachycardia. Now the first thing you need to do is evaluate whether or not you got a pulse or not. If you get, and this is VTAC, ugly. If no pulse, we're going to begin CPR. Okay. If it's not generating a pulse, okay, then we got to generate the pulse. So we start CPR and we begin defibrillation. If you got a pulse, there are some medications that can treat it. But the key part is check for a pulse first. If I see this on a monitor, check for a pulse. So, unless I know that there's a pulse, I don't know, what to do next. I need to assess for a pulse. We're going to treat that pulseless VTAC just like we treat this. And this is VFib. P wave, not a chance. QRS complex, not a chance. What do you got? Ugly. This undulating wave that's there. Blah, blah, blah. Does it generate any kind of cardiac output? Nope. They're dead. Another wonderful picture of it. The only way to get out of VFib is to defib. And that defibrillation process is where he places some energy through the chest. We talked about the AED last semester. I'm not going to concern myself with blocks for now, so let's just skip these slides because that just gets more and more confusing for you. But there is a situation where there can be more than one P wave for every QRS complex. How rude. But I don't want to go through that. Let's skip that too. ST elevation we talked about. Two other arrhythmias that we have. One is called asystole. What does asystole look like? Flat line. Did you ever notice on TV, somebody comes in and they got a normal sinus rhythm and then they go to asystole? That never happens. Just saying. Okay. But asystole is an absence of any kind of electrical activity. Flat line. Pulseless electrical activity, PEA. What the hell is that? It's a condition where you end up having normal, or we end up seeing an ECG beat tracing that should be generating a pulse, but it's not. Okay? Where you see an ECG pattern that should be generating a pulse, but there's no pulse. Something's wrong. And there's a whole bunch of reasons as to why, which I don't want to go through now. But can I have a normal sinus rhythm with no pulse? Yes. We call that PEA. Why is it like that? If I had a tension pneumothorax, when am I going to have any cardiac output? Probably not. Heart twists, aorta twists, kinks off. Will I still have an ECG tracing? For short term, yeah. That's one example of a cause of PEA. There's a whole slew of them, like 10 or 11 later. Okay, asystole PEA. And here's some of the underlying causes that you can end up seeing. And as you can see, they're usually, that's pretty profound. ECG pattern, no cardiac output. So, for the exam, what I want you to know are these tracings. Normal sinus rhythm, that should be a gimme. Okay. Heart rate 60 to 100 beats per minute. P wave, QRS complex, everything looks normal. Sinus brady, it's just slow. Sinus tachy, it's just fast. Flutter's got the sawtooth. Fib's got the underlying baseline that looks ugly and usually is irregular. Irregular, because there is a rhythm that is regularly irregular, but we won't talk about that yet. It's one of the blocks. PVC, big uglies, right? When are they bad? When they come with friends? When they come with friends from different neighborhoods? When they're on the T wave. One other one, but I can. VTAC, VFib, and asystole. So you should be able to identify those rhythms. I don't think that's too much to ask. And again, you can find it in Egan. We don't have videotapes, so forget that. There is a homework assignment that you should have in that in your packet. We'll make it due January 24th, which I think is the next exam. Keep going. Keep going. Yep. Not this one.
It's after this stuff.
Not the funny ones, guys. Those don't count. This is a joke. You know, the H&R block. I kind of like that one. Yeah.
But we got half of our, on one side is AQ.
I will send you that last page. And I'll also post the answers in Canvas. But I think that may help you to memorize. Okay. Let me hold off on demoing the PE. I don't know, we've got a lot of time, and I don't want to rush through it. So we'll start off tomorrow by doing a demo of the PE.
8 a.m.
Okay. 8 a.m.
And we got our guinea pig over there, right? The only guy in class.
Nathan's not going to come in, though.
Come on, Nate. You don't want to take off your shirt for all these
Come
on now. Ladies, bring dollars. Sorry.
I thought it was a new star. I was like, I know I've seen someone who had
All right. Questions?